Hello, Santu, Amit, am I audible? Hello.
Somudada, you are audible, quite audible.
Great. Very nice and crystal clear sound, Amit. Thank you.
Hi, Shamanduda. Good evening.
So, good evening. Just checking.
So,
Everything is fine.
Shamanduda, let me just introduce Gayatri. She's from High Doc. Amit
Hi,
is being.
Gayatri.
I have just allow Amit to be compliance monitoring. So he will
Perfect.
take all the photographs. He will take
Everything.
all the photographs and everything. Okay.
Very nice. Good.
So event attendee link will be activated at 6:50.
Attendee link will be activated at 6:50. Fantastic. Okay. And the faculty.
যারাই ওখানে এখন ঢুকতে যাচ্ছে তাদেরই বলছে 20 minutes to go. 15 minutes to go.
That is there. It is counting now. Shantu, can we
and we will be live on 7 p.m. এটা লেখা আছে.
Right.
Shamanduda, you are saying something.
I'm telling that can we share the slide now, Shantu, so that we can see the screen how it is looking like, or the slide is with the speakers only?
Slide with the speaker only. They will share.
They will share from their laptops. No problem. That's
absolutely.
Mm-hmm.
You can on your camera. I want to see you.
No problem.
Who is asking about your problem?
Unable to access camera. Why is it?
ऐसा हो ही नहीं सकता है. आप कैसे ज्वाइन किए हो? लैपटॉप से?
नहीं, आईपैड से.
जब आप आईपैड से ज्वाइन किए हो ना सुमंदुदा, तब उसने पूछा होगा आपसे कि इनेबल वीडियो
परमिशन
या मैं काम करता हूँ, मैं लीव करके फिर ज्वाइन करता हूँ. ठीक है ना?
हाँ. Yes.
Hi Varun, good evening. Varun, good evening. Oh, Tahir. Okay. Hi, Tahir.
Tahir actually.
Okay. Hi, Tahir. Good evening.
Hello. Good evening, sir.
How are you?
Fine, sir. How are you?
I'm fine. Thank you.
So, any problem and difficulty?
As of now, no. I think Dr. Basu has joined. Dr. Basu. Tahir?
Yes, sir.
Okay, no, ठीक है.
Yes.
Sir, good evening.
Shantu,
can
you please remove your t-shirt which is hanging beside you?
করে দেবো, সব করে দেবো. আমি দেখে নিলাম সব কি এমন আছে.
আচ্ছা.
I will arrange a good background. Don't worry for that.
Okay. Allow Zoom to access your camera from device menu. Setting privacy.
One thing, if you see right side of your screen where participants is being showing, okay, so there is being mentioned panelist 6, but no name is being featuring under that.
Panelist 6, names are featuring. Somendu, Tahir.
No names is being featuring in screen.
Okay, but in my screen I can see the names.
अरे वो तो मुझे भी दिख रहा है. लेकिन मैं लैपटॉप से ज्वाइन किया हूँ ना, वो राइट में जैसे आप पार्टिसिपेंट क्लिक करोगे वो पार्टिसिपेंट ऑप्शन राइट में चला जाएगा. ठीक है,
राइट.
वहां पर नाम आता है, देखो अटेंडी 0, पैनलिस्ट 6 दिखा रहा है ना, और पैनलिस्ट के नीचे नाम चाहिए टोटल, वो नहीं आ रहा है.
ओके.
ओ आ गया. Got it.
I can see that.
आ गया. Sorry, my apologies. Actually, I was clicked on attendee. Dr. Basu.
ডক্টর বাসু জয়েন করেছেন?
হ্যাঁ, দেখছো না দেবাশিস?
না, আমি দেখতে পাচ্ছি না.
Sir, so what I was telling is I'll paste that questions from the link right here in the Zoom chat box. The questions will which the
So
attendees will post.
not in Q&A.
That's also fine. Q&A or chat box, anything is fine.
Okay, so
If
just
you
open both the
want
options so that yes.
post to some particular person privately, then let me know, or else I'll post to everyone.
No issue. So keep open Q&A and chat box both for put the question.
Yes, sir. Anyone can view the Q&A and chat. All the panelists can view that.
So Shomenduda has also joined as an attendee.
Yes, sir. I'll add.
No issue.
Yeah, now it's fine. Now I think I am visible. Hello. Shantu, can we have some backdrops screen like day and ESI update, something like that right now? What would be the visibility for the audience if they join right now?
Okay, so Tahir, usually mone hoy hobe na. Tahir,
Hello. Yes, sir.
can we flash the agenda for the that agenda of ESI and
Yeah.
day update, that agenda flash for the attendees, because
Yes,
those
sir,
are
we can.
joining right now. Okay.
Yes, sir. We can start the share screen right now.
Please start sharing the screen.
But sir, the attendees can only see after we go live. Right now, the attendees can.
That's fine. That's fine. But we can see, right?
Yes, sir. We can see.
Can you please upload the screen? ইন্দ্রজিৎ দা জয়েন করেনি সন্তু এখনো?
করে যাবে। এটা কি
সঙ্গীতা জয়েন করেছে। গুড ইভিনিং সঙ্গীতা।
Good evening.
গুড ইভিনিং। দেবাশিস দা গুড ইভিনিং। জয় মা। দেবাশিস কিছুই বলছে না।
ডক্টর চৌধুরী, এটা ডক্টর দেবাশিস চৌধুরী হতে পারে।
ওর দেবাশিস চৌধুরী। ও স্যার জয়েন করেছেন। হ্যাঁ
পরে ভাবলাম।
ইয়েস স্যার গুড ইভিনিং। তুই বললি দেবাশিস দা, আমি
ভেবেছি ডক্টর বাসু, তারপর পরে মনে হলো ডক্টর চৌধুরী হতে পারেন।
প্যানেলিস্ট আগে জয়েন করলে একটু মানে সাউন্ড গুলো চেক করে নেওয়া যেত।
Sound absolutely perfect. Your sound is coming like Amitabh Bachchan.
আচ্ছা।
সোমেন্দু দা আর কোনো টিবিএম দের কিন্তু আমি প্যানেল অ্যাক্সেস দিচ্ছি না।
No, no one else. না বিউ হেডরা জয়েন করতে পারেন, মিস্টার দীপক অরোরা।
আরে ডক্টর দিলীপ শাহ অ্যাটেন্ডি হিসেবে জয়েন করেছে কেন?
অ্যাটেন্ড হিসেবে জয়েন করেছে?
হ্যাঁ,
ও মাই গড,
ওনাকে বলে দাও যে আরেকটা লিংক পাঠানো হয়েছে ওনাকে, ডাইরেক্ট লিংক।
ডে থেকেও মেল গেছে। আমি তো দেখো সোমেন্দু দা এটা।
Sahir will promote them to panelist.
या प्लीज।
Yes,
बट
yes.
ये एक्चुअली ये इशू ना हो इसलिए तो मैंने लिंक भेज दिया था सोमेंदु दा।
अरे this is a job of Arindam. No, he was supposed to just hold on for a second.
Don't worry, Gayatri will make him as a panel. Don't worry for that. But आगे देख लो आगे बाकी doctors. Gayatri, can you please promote Angshuman Bhattacharya in panel as well? Yeah. Hello.
Yes, sir.
Angshuman da.
Hi, hello.
হ্যাঁ, হাই গুড ইভিনিং। তুমি অ্যাটেন্ডি এটা দিয়ে জয়েন করেছিলে, আমি যে লিংক পাঠিয়েছিলাম প্যানেলের লিংক।
আমি তো ওটাতেই ক্লিক করলাম, তোমারটাতেই। তুমি যেটা ওটা ইমেইলে যেটা পাঠিয়েছিলে
লাস্ট আজকে যেটা সকালে পাঠিয়েছিলাম,
এটা কোনটা দিয়ে ঢুকলাম জানো?
না না তুমি ওই প্যানেল দিয়ে ঢোকোনি, ওর জন্য তুমি অ্যাটেন্ডি হয়ে গেছিলে।
ও আচ্ছা, ও ডাইরেক্ট লিংক বলে কি একটা পাঠিয়েছিলেন, ওটাই ঢুকে পড়েছিলাম। যাই হোক,
হ্যাঁ আমি ওটা দিয়ে জয়েন করতে বলেছিলাম, নো ইস্যু। ঠিক
ঠিক আছে।
Dr. Dilip Sahu, good evening, sir. This is Somendi here. Can you hear us? Dr. Bhattacharya, sir, good evening.
Good evening. Good evening.
Yes, yes. Hello, sir. Good evening. Good evening, sir.
Hi.
Santa, I think everything is proper, right? Panelist and Dr. Bhattacharya is also very much visible in this.
Sangita, I think you should follow up the attendee as well.
হ্যাঁ আমি করছি।
I think attendee link is open now, right? Anybody can join. It's already 7 o'clock, close to 7.
Hi, hello.
Good evening, everyone.
Good evening, everyone.
Good evening, sir.
Good evening.
Good evening. Good evening. Can you hear me properly?
Yes, absolutely. Yes. Absolutely. I think it's Dr. Bishash.
Dr. Bishwas. Good evening.
Good evening. Good evening.
Tahir, can you please take Dr. Shomik Goswami in the panel? Okay, okay. Hi,
Good
sir.
evening.
Good evening.
Good evening.
Good evening.
Good evening.
Evening.
Good evening, sir.
Good evening.
Dr. Goswami.
Hello, sir.
Hello.
Should we go live, sir?
Hello, Santu sir. Shall we go live? Hello.
Hello, sir. Santu, sir.
Hi, Deepak.
Hi.
Toshik.
Hello.
After a long time, huh? Hello.
Yeah.
কেমন কেমন আছিস?
দেখতে পাচ্ছি না তোকে। কোথায় আছিস?
Hi, Dr. Deepak.
Hi.
হাই ভালো আছিস তো?
হ্যাঁ একদম ভালো, খুব ভালো।
আমি আর ডক্টর দীপক হচ্ছে
আরজি করে
we used to study together. Close friend.
অংশুমান,
ভিডিওটা দেখতে পাচ্ছি না কোচে।
অংশুমান
আমি এবার দেখতে পাচ্ছিস?
হ্যাঁ স্যার বলুন।
অংশুমান, আমি তোকে একটুখানি কথা বলে নি। আমি জাস্ট পৌঁছলাম, আজকে তো অন কল ছিল, আমি কিছু নিয়ে বসতে পারিনি। আমাকে যদি একটুখানি কৌশিক বাবুকে আগে বলে নিয়ে আমাকে যদি তুই দিস, তাহলে আমি একটু সময় পাবো।
আচ্ছা,
আফটার ডক্টর কৌশিক, ইফ আই ক্যান কাম ইন।
ঠিক আছে। ডক্টর কৌশিক তো কোভিড বলবেন। ডক্টর কৌশিক, ইজ ইট কমফোর্টেবল আমি আপনাকে আগে দিলে?
একটু কৌশিক সাহেবকে জিজ্ঞেস করুন না, ইফ ইজ কমফোর্টেবল।
হ্যাঁ হ্যাঁ, কোনো অসুবিধা নেই।
তাহলে আমি একটুখানি, আমি আমার আজকে প্রচুর বৃষ্টি টিষ্টিতে আমি অন কলে আটকে গিয়ে এই মানে
হ্যাঁ হতে পারে।
ওকে, ঠিক আছে স্যার। তাহলে ডক্টর কৌশিক আপনাকে আমি আগে রেখে দেবো।
তাহলে কৌশিকের পরে আমি ঢুকবো আর কি।
ঠিক স্যার।
সৌমিকরা জয়েন করে গেছে?
হ্যাঁ হ্যাঁ,
আমি জয়েন করে গেছি।
Shomendu, are you there?
ঠিক আছে, ওকে।
Shomendu, are you there? Shomendu?
এটাকে সাউন্ড অফ কর, ওকে ভ্যাকসিনটা নিয়ে যায় যেন। ভ্যাকসিনটা নেয়নি আগের দিন।
এই যে এইবার দেখুন হবে, হয়েছে। স্টার্ট ভিডিওতেও দেখাচ্ছে ওরকম, ওটাও কি ওরকম ইয়ে করে দেবো? আচ্ছা, ভয়েসটা মিউট করে দিলাম, ঠিক আছে। ঠিক আছে এবার? আচ্ছা।
Hello, Santu sir, can you hear me? Hello. Hello, Santu sir. Gayatri ma'am, can you call Santu sir to just verify that should we go live?
Yes.
Yes, ma'am.
ডক্টর কৌশিক বিশ্বাস স্যার, গুড ইভিনিং। কেমন আছেন স্যার? ইউ আর মিউটেড স্যার। Dr. Deepak Gupta, good evening, sir. Dr. PK Singh,
Good evening.
sir, good evening.
Yeah.
Good evening.
Am I audible?
You are very much audible. Very much audible, sir.
Thank
we
you.
can hear you.
Am I audible now?
Yes, yeah.
Okay.
Sir, we are live, sir.
लिस्ट के हिसाब से ज्वाइन किया हूँ.
Sir, we are live now. The attendees can view us now.
Santu, should we start now?
We should start now, I think.
Sure.
So, good evening, everybody. We all know this, the treatment of diabetes is not anymore a glucocentric treatment. We are actually treating diabetes to give our patient a better, fruitful life, free of all complications, micro and macrovascular. And as you know, the current era is actually an evidence-based medicine. So day by day, there are new studies are conducted and new results are coming in. By that, new dimensions for the treatment of this silent killer must. Now, our job is not finished here. We need to get updated, and by that we need to update our colleagues to treat this diabetes with this changing in the guidelines. We must update ourselves as well as other colleagues. Dear friends, we are all going through a very tough time in today's situation due to COVID, and the end is still unknown, rather unexplored. In keeping all these things in mind, day, the Diabetic Awareness and You, in association with ESI, is conducted first ever digital CME the ESI update on diabetes management. I welcome you all in this webinar to witness and to listen all the eminent speakers in our eastern part of this world, our country. They is also organized, beside this physical health or camps to help other in this COVID situation, they are organizing the national and international seminars for this with this target. Now, we have 4 lectures, and then we have a panel discussions with all ESF faculties. Now, without spending much more time, I would like to invite Dr. Kaushik first. He's a consultant diabetologist in Apollo Gleneagles Hospitals. He's a consultant endocrinologist in Medica Super Specialty Hospital, Kolkata. He will be talking on COVID-19 and the diabetes management. Before handing over to him, sir, we have this is a time-bound program, so I would like to request all speakers to be on time so that you can finish in time. Thank you. Dr. Kaushik, it's all yours now.
Hello, am I audible now?
Yeah, audible.
And my slides are moving?
Yes.
Yes.
Okay, thank you. Thank you very much, organizers, for having me here. I'm proud and privileged. Good evening, everyone. Today, my topic of discussion is diabetes and COVID-19. We know that since past few months, how that filthy pandemic has shattered the life of the human race. Today, in my discussion, I'll cover these points: high-risk populations for severe COVID-19 infection, providing optimal care for patients with diabetes during COVID-19 outbreak, what to do if our patient with type 2 diabetes has the COVID-19 infection. We know that possibly type 2 diabetes per se does not increase the risk of contracting the COVID-19 disease or SARS-CoV-2 infection. However, there is a higher risk of COVID-19 related hospital death for patients with uncontrolled diabetes, obesity, heart and kidney diseases, and other comorbid conditions like malignancies, COPD, etc. Now, not only that, as the number of comorbidities increases, there is exponential increase in the intensive care rate or invasive ventilation or death due to COVID-19. And as studies have shown, and as our clinical experience is there, that during or at admission, blood glucose as well as glucose control during the hospital stay is very strongly related to COVID-related outcomes. And you can see that the poor glycemic control is associated with lower survival rates among hospitalized patients with type 2 diabetes and COVID-19. What could be the reasons of that increased severity of COVID-19 related adverse outcome in diabetes? Few are established theories and some are postulations. Like glycemic instability in terms of hyperglycemia and possibly hypoglycemia are directly contributing to the morbidity and mortality of COVID-19 in diabetes. We know diabetes is associated with defective immune response in terms of impaired T cell response and natural killer cell response. And as I have discussed before, the most of the comorbid conditions like obesity, heart disease, kidney diseases are often accompanied by type 2 diabetes mellitus. There are some other postulations or conjectures like that the type 2 diabetes is a basically is a chronic state of subclinical inflammation, and it has been shown in studies that the perturbation of cytokines such as interleukin 6 in patients with COVID-19 and diabetes is much higher than in patients with COVID-19 alone without diabetes. And diabetes is a prothrombotic state. We know that there is increased level of plasmin and increased level of PAI1, and there is reduced S2, and there is increased expression of furin in type 2 diabetes mellitus. Furin is a cofactor or co-receptor involved in the entry of the virus into the cell. So possibly this could explain the severity of COVID-19 in type 2 diabetes mellitus, where approximately 9% of case fatality has been reported overall. Now there has been a bidirectional relationship of between SARS-CoV-2 and diabetes mellitus. There could be two types of scenarios as far as hyperglycemia is concerned when a patient is infected with SARS-CoV-2. A patient may have pre-existing diabetes, which may get worsened. The metabolic control may get worsened during the admission, or there could be newly detected hyperglycemia, which is again may because of stress-induced hyperglycemia or a second entity where there is true development of diabetes or new onset diabetes, possibly because of destruction of insulin secreting beta cells by the SARS-CoV-2 or coronavirus, because islets of Langerhans expresses exuberantly the S2 receptors. And it has been shown that patients with type 2 diabetes mellitus often are associated with sudden onset or unexplained or rapid deterioration of metabolic control, and possibly it is something to do with the islet cell Langerhans destruction by the virus associated or compounded by the cytokine storm. Now, when that hyperglycemic milieu is accompanied by obesity, inflammation, coagulation, older age, hypertension, CKD, etc., the obviously the outcome is extremely poor. Now, the point is to provide optimal care for patients with diabetes during the COVID-19 outbreak. We know that stringent hyperglycemia is of utmost importance in patients with COVID-19 infection, but there are several hindrances or obstacles to give proper management of patients with diabetes. In patients infected with SARS-CoV-2. There's a reduced patient healthcare touch points, leading to less frequent healthcare professional visits, difficulty in frequent testing and monitoring. There could be difficulty in maintaining a healthy lifestyle. Patient may not be able to procure healthy foods like fresh fruits and vegetables, may not be able to procure medications and gadgets involved in diabetes management like glucometer or strips. Some of the technology-based solutions may not be applicable or easy for all. So these are the obstacles. Now, this is the consensus recommendations for COVID-19 and metabolic diseases. We know that most of the patients, mild and even moderately symptomatic patients, can be treated as an outpatient care, and they can be treated as their home. But this point has to be emphasized, and a thorough discussion or shared decision making with the patient is mandatory while treating a patient of COVID-19 at home. There should be sensitization of patients with diabetes for the importance of optimal metabolic control. Optimization of current therapy has to be done, and it has to be done frequently. And patients should be advised not to discontinue therapies prematurely without any advice of healthcare professionals. And utilization of telemedicine or teleconsultation should be encouraged much more. Now, the management of diabetes with COVID-19 in hospitalized patient is not much different. In non-critically ill hospitalized patient, we often treat them with basal bolus insulin regimen, and in critically ill patients who is admitted in ICU, in variable insulin intravenous insulin infusion with multiple blood sugar checking are recommended. However, there is a catch, as the inpatient management of hyperglycemia require frequent monitoring of blood glucose. There could be frequent proximity between the patient and the healthcare professionals, which could have deleterious health hazards. So, in my view, every ICU in a hospital should have its own customized protocol for managing diabetes as well as frequency of monitoring of blood glucose, obviously not compromising the health of the patient as well as the safety of the healthcare professionals. Now, obviously the pre-meal blood sugar target in hospitalized patients, the pre-meal blood sugar should be less than 140, and random blood sugar should not cross 140 milligram per deciliter. Now, while treating a patient, as a home care basis, frequent monitoring of blood sugar by themselves using a glucometer is recommended, and they should all follow sick day rule. We know that in period of any acute illnesses, all patients should follow some general rules in patients with diabetes, be it type 1 or type 2 diabetes. To minimize the risk of complications, they need to monitor. Patients should take increased amount of fluid or water to prevent dehydration and try to eat as normal as possible. They should frequently monitor blood glucose ranging from 2 hourly to 6 hourly. And if blood glucose is more than 270 milligram per deciliter, they should definitely check for urine ketone. If it is positive, they should seek medical advice. Now, they should also be aware of symptoms of dehydration and impending decay also, like the thirst, the dry mouth, passage of large amount of urine, tiredness, weight loss. They should check their weight every day. And as I mentioned, if ketone bodies are there, they should urgently call their healthcare professional. Now, they should seek advice if there is persistently elevated blood glucose, if there is abdominal pain and vomiting, which could be the signs of impending decay, or if there is any other signs or symptoms of diabetic ketoacidosis, they should seek immediate advice from healthcare professionals. Decay occurs usually in patients of type 1 diabetes, but it also occurs in type 2 diabetes at times of severe illnesses. And nowadays, as we are treating our type 2 diabetes patient with SGLT2 inhibitors frequently because of their many important non-glycemic benefits, so SGLT2 associated non-euglycemic decay, the possibility of it rises significantly in patients when infected with COVID-19. So in a hospitalized patient, SGLT2 inhibitors therapy should be discontinued immediately if there is any indications of decay. Now, the patient should be advised to take medications as normal unless advised otherwise by a healthcare professional. But these medications should be stopped temporarily, either to avoid hypoglycemia or to avoid acute renal injuries like sulfonylurea, ACE inhibitor, diuretics, metformin, ARBs, NSAIDs, and SGLT2 inhibitors. You can remember it by the acronym SADMANS and SADMANS. And once the patient's condition is stable after, say, for 48 hours, then these medications can be resumed. During the period of treatment interruption, healthcare professionals need to consider initiating insulin therapies or adjusting insulin doses, or to shift to other antihyperglycemic drugs. Now, COVID-19 infection in people with or without previously recognized diabetes increases the risk of emergency state of hyperglycemia with ketosis. This is very important. Ketoacidosis or ketosis rather is very common in patients with hospitalized patients with COVID-19 and diabetes. It is mostly seen in patients who are already on SGLT2 inhibitor or newly detected type 2 diabetes mellitus. And the course can be quite unpredictable because, as I have mentioned before, the virus can rapidly destroy the islets of Langerhans. So, and COVID-19 disease may precipitate atypical presentation of diabetes emergencies like mixed DKA and hyperosmolar states. So, recommendation is check blood glucose in everybody on admission and check ketones in everybody with diabetes being admitted, everybody with an admission glucose over 12 millimole per liter, stop SGLT2 inhibitor in all people admitted to hospital, and we have to provide adequate amount of carbohydrate also to prevent starvation associated starvation ketoacidosis. Now, the fluid requirement definitely vary in patients with COVID-19 and diabetic ketoacidosis or HHS because there is more likelihood of pulmonary edema and myocarditis. So the fluid therapy should be tailored, and infusion pumps may not be available to manage hyperglycemia using intravenous insulin, as they can be consumed in other purposes such as for sedation in ICU. Now, small studies have shown that in the setting of COVID-19, mild DKA can be managed by frequent administration of short-acting insulin analog, and obviously this should be taken where those pumps are not available and patient has to be saved. Another important point is that it has been shown there is significant elevation of insulin resistance in patients with COVID-19 in ICU admitted patients. In general, in type 2 diabetes who are admitted in ICU, there is rise in insulin resistance. However, as there is exuberant use of dexamethasone with very, very high dose, the insulin requirement can be extremely high, such as up to 20 units of regular insulin per hour. We have seen cases like that. And patients, as often are ventilated in a prone position, there could be accidental interaction of feeding, so paradoxical risk of hypoglycemia are also be there. So we should also take care of that thing. The cardiovascular risk factor and the lifestyle management are important factors that should not be forgotten during the COVID-19 outbreak in outpatient setting. So lifestyle modification should continue to go on. Now, we physicians have a duty and responsibility and some means for our patients to communicate with them regarding the issues of insulin titration, regarding management of hypo and hyperglycemia. We have to provide a means to communicate with patients with diabetes for continuity of care. We should develop a system optimizing emails, video, phone calls as a means of consultation so as to provide continuity of care. And that is the area where the utility of telemedicine or teleconsultation pops out. And if you see the decline in outpatient consultation per specialty, in the field of endocrinology, there is 46% reduction in OPD patients. And this is largely because of increased utilization of telemedicine in our patients in OPD basis. So finally, what to do if your patient with type 2 diabetes has the COVID-19 infection? As I've said before, the majority of patients can be managed at home. So ensure the affected person is isolated for the recommended guidelines. Ensure that they should follow the general sick day guidance. But do not underestimate the potential for severe complications in patients with diabetes. Severity of COVID-19 may be hidden by an initial mild presentation of infection. It can be type 2 diabetes can have a masking effect on symptoms like fever, So whenever the patient is actually severely affected, there could be lower incidence of fever in some cases. So a lower threshold for hospitalization for patients with diabetes and COVID-19 may be considered due to the increased risk of complications. Now, we will quickly go through the advantages and disadvantages of popular anti-diabetic medications. Like if you consider metformin, metformin are to be discontinued only when there is gastrointestinal adverse effects like nausea, vomiting, diarrhea, or there is respiratory distress, renal impairment, or heart failure to
Dr. Kaushik,
prevent
sorry to interrupt you. You have 1 more minute.
Yeah, sure. I have just two or three slides, sir. So there is heart failure to prevent lactic acidosis or avoid lactic acidosis. If we consider DPP-4 inhibitors, it is associated with almost zero risk of hypoglycemia. It's available for wide renal function range. It has potential anti-inflammatory action, potential modification of SARS-CoV-2 binding to DPP-4 has been reported in small trials, subclinical trials. SGLT2 inhibitors is a very good molecule for treating our patients with type 2 diabetes mellitus because of very non-glycemic benefits, and there is no risk of hypoglycemia. But in the setting of COVID-19, only in select group of mild COVID-19 patient we can use it. Otherwise, there will be risk of hypovolemia, electrolyte imbalances, and euglycemic ketoacidosis. GLP-1 receptor agonist has been found to be associated with protective effect in terms of pneumonia. However, these agents are also to be avoided because of the gastrointestinal side effects, which can lead to aspiration pneumonia in patients with COVID-19. Sulfonylurea obviously can be used in a select group of patients, but there is always risk of hypoglycemia. Pioglitazone, in spite of having an anti-inflammatory action, there is often a risk of fluid retention and promotion of heart failure. So better be avoided. Insulin remains the treatment of choice for hospitalized patients with COVID-19. But as soon as the patient is discharged from the hospital, the game is not over. We should be prepared for a long haul and the multiple waves. There could be impact of resource restriction on urgent non-COVID conditions, impact of interrupted care on chronic conditions. There could be psychic trauma, mental illness, and finally, economic fallout. All are going to affect the management of the chronic disorders in near future. So disasters and pandemics pose unique challenges to the healthcare delivery. So in my final slide, the key considerations for optimal care of patients with diabetes during the COVID-19 outbreak, you should consider optimal glycemic control, cardiovascular risk factors, and lifestyle management should be continued, and adherence of medication should be ensured, reassurance and support to be given. And for treating patients with diabetes, those are infected with SARS-CoV-2 or having COVID-19 infection, follow seek the guidance, monitor, seek advice, and adjustment of medications. Do not underestimate the potential for severe complications in patients with diabetes. Thank you. Thank you very much for kind listening.
Thank you, Dr. Kaushik, for this kind practical-based knowledge of managing COVID and diabetes. Now, this is my humble request because we have already started late. So, to coming lecturers, please maintain the timing schedule given to you. So, now to discuss about the evolution of insulin, I would like to request to invite Dr. Devashish Basu, President of DAY. Sir is consultant endocrinologist in Apollo Gleneagles. So, Dr. Devashish Basu, sir. Sir, please maintain the times. Thank you, sir.
Am I audible?
Yes, sir. Yes, sir. Nice.
Yes.
Okay. So thank you, Angshuman, for giving me this opportunity. And I'm extremely happy to share the platform from DAY, which is our organization. And I think I cater some justice from the organization point of view. Now, insulin is a part of my life as well now. And Angshuman, being associated with me at Apollo, has had the privilege of prescribing almost 10 prescriptions on a given day average. And he has seen the change that has been brought into human lives. And I would like to say that since the dawn of time, we have searched for many ways to make life easier for us. But the modern age has given us something amazing in terms of technological advances. And these iPhones and other. I was at Apollo today. We had an all call. A lot of gadgets to actually catch those this GPS system to the COVID kind of COVID-19 cases who are the track cases, the index cases. So a lot of things are happening. But 2020, it is just about 100 years that insulin has been discovered. But how many people actually have been doing well with insulin is the question, and how many people have got the chance or can afford to buy insulin, can make actually insulin which is available all across the world. These are the things that we have to think of and ponder about. Now, I will just briefly touch upon these, the historical timeline. The pissing evil with diabetes mellitus was introduced actually in the 1960s, in the 1670s by the British physician Thomas Willis, who said that who differentiated actually diabetes insipidus and diabetes mellitus from this particular sweetness, because he tasted that, and he called it the pissing evil. And then this is a very important slide. The flame of hope, which burns out outside the Banting House Museum in London, in the Adelaide, that's the Adelaide Street, Adelaide in Australia, London in the UK, off London in Ontario, which is in Canada. So, 3 countries are there on this street, which is dedicated to the life and career of Sir Frederick Banting. The flame of hope actually honors whoever is in the world affected with diabetes. And the Queen Mother lit the flame in 1989. It still glows. Unfortunately, in June mid, there were some vandals who extinguished the fire for a while, and then it still is glowing now. So we must, and this was actually done in the memory that the flame will go on till there is a cure for diabetes. Now, as I was making these slides ready for next year's big battle, I came across actually the fight between who actually should be credited to be given the merit of discovering insulin. And it is seen that between 1914 and 16, this gentleman, whether it's Frederick Banting Best or this man, Nicolae Polescu, Romanian, he conducted a lot of experiments and he extracted the molecule in some sort, injected them into the diabetic dogs and measured the blood sugar levels. Now there was a distinct drop from those who were pancreatomized, and then what held him back was his military activities during the First World War. Actually stopped his paper to be published on time. In fact, his most comprehensive paper was on pancrean. Pancrean is actually now considered to be in insulin, but it was never published until the end of August 1922. By the time Banting and Best has already made their name, and they were almost ready to get the Nobel Prize. So that is history. And then we have this the beginning, Minkowski. We know Minkowski, Mehring and Minkowski, the German physicians, they conducted experiments on the total pancreatectomy in dogs, and they found out the pancreatic powder extracts. And this experiment gave them also. Mehring actually was able to induce an experimental diabetes in animals, administering something like Florizin, which is actually now SGLT2 inhibitors. And they got a lot of amazing results. Then it was Eugene Opie. Eugene Opie was the person who made an important discovery, saying that there are these islets of Langerhans. People came to know from Paul Langerhans, but these are the lesions which are happening in the islets, and that causes that may have some hormone. So there is a link between diabetes and carbohydrate metabolism. And more than 20 years later, obviously, when iletin was discovered, they named it as insulin. This is the timeline of Eugene Opie to finally 1920, and taking it forward. What they did, Banting and Best. Banting, you all know that he's an orthopedic surgeon, went for training into MacLeod's lab, and then MacLeod gave him Charles Best, as an associate. They blocked the pancreatic duct and they recreated diabetes, and then they had the extract, and then the dogs improved. So this is Banting and Best. The dog, this dog they're talking about is Marjorie, from whom who actually established the point that this is insulin. So the efficacy was demonstrated all over, and they took the production issues. First, a lot of people might not know this very interesting stuff, that this is a gentleman called Joe Gilchrist, a fellow classmate of Banting. He also had diabetes, type 1 diabetes in 1970s and 1917. And in the 3 years that he was struggling, he was also doing the same clinic with Banting. And then when it was discovered, they gave him the oral preparation. And see, there's written here, December 20th, they gave him, phone Joe Gilchrist, gave him that extract by mouth, empty stomach, December 21, but no beneficial results. But this gentleman suffered a hypotensive hyperglycemia, one of the side effects of insulin therapy. This is, of course, our famous Leonard Thompson, the first individual who got the shot. And his words were mentioned about him. It was mentioned in the pancreatic extracts in the treatment of diabetes mellitus, which came out in March 1922 in the Journal of Canadian Medical Association, that on the 11th of Jan, he got the first shot, but it was so allergic that he got a sterile abscess, etc. Just about 12 days later, this gentleman, who was actually recruited by MacLeod, the biochemist, Collip, he purified the extract, and they gave the new shot, and which actually made him back to life, which was on the 23rd of January, our Netaji Subhash Chandra Bose's birthday, and not the same year, of course. And then Collip, actually, there was a lot of fight. Collip did not want to give the process of purifying it, the contaminations. So here, Banting is asking this question, how did you do it? And Collip replied, I have decided not to tell you, stuff like that. But Nobel Prize in the meantime was announced to be awarded to Banting and MacLeod. And then Banting, of course, we know he shared it with Best, and MacLeod with Collip. So they became friends and the Fantastic Four. But whether they actually became friends, God also doesn't know. But the world now knows, actually, unfortunately, only one name, perhaps Banting, as the discoverer, though he was a co-discoverer out of 4. This is how things happen. The timeline: $1 with $1, they sold it to the rights. Banting sold the rights to the University of Toronto, and something that goes in the memory lanes of his credibility of big work. And this is when Eli Lilly was contracted to develop a standardized product. And during the first 5 months of 1923, they distributed over 7 million units of insulin. And then there was one gentleman called Krosberg who came forward, and he bought the rights to Krog was from Copenhagen. And he met with Banting and MacLeod, and he received the authorization from the University of Toronto to bring insulin to Scandinavia. So he got that into the Nordisk insulin lab. So Lilly and Novo, so they all came forward. But what happened in the meantime was this post-insulin discovery. Look at this bar diagram. Pre-insulin era is 1897 to 1922. Insulin era is 1922 to 1945. So this was, Brostov's paper, which he published in 2007. But this was actually talking about how the whole expectancy of life changed post-insulin era. See, if you're at the age of 30, So there was a 29-year-old gentleman who was predicted to only live for 4.1 years in 1920s, 21. But if he's born after 22, then perhaps he's going up 20. And then if he's born in 1940s, early 40s, then he can live up to 30 years. So from 30 years, 60 years. So things improved definitely. And this is the new stage of the evolving story. And this is how we see the Banting best insulin to animal insulin production. And then you had the NPH coming in the 50s, and there's a certainty of the supply chain was a big question there. So how many, it's Lilly and Novo, there's just two, main names to be there in the market. And then you had the mealtime injection for the Prandil ones, the rapid act, the regular ones before the meals. And then you had in the 50s, you had the lenti. Lenti means like, music. You have the lento, the slow tempo. So these all came in one after the other from the Nordisk Insulin Laboratorium or from the Lilly lab. They are all coming together. And there were a lot of also biochemical studies going on in organizing the molecule in a better way, structurally, functionally, to see less variability, lower nocturnal hypos, and lower risk of, all combined hypos, and the flexibility. So these are the people who got the Nobel Prize with diabetes-related research. So mind you, 7 people got the Nobel from this peptide hormone. And this is something in 1920s, the first insulin short-acting acid page, only bolus regimen, no basal. So this was for the bolus regimen. 1940s, the first end page came, and the Hagedorn, the Hans Christian Hagedorn. So that was neutral pH, and that gave you basal bolus, possibly ideally, but too many injections came into that. And then 1961, it was Actrapid. So a little rapid acting than the regular one. Neutral pH, split mix became possible. Now this premix concept could come in. And then you had in 1964 fixed dose combination of 30-70, 50-50, 25-75, all kind of coming in. But 25-75 only came in with the analogs. So the analogs revolutionized treatment. And we know that analogs actually talked about more physiological advantage for the human substrate. And what it actually had was in the process, in the timeline we had in 1982, I remember when I entered medical profession, MBBS course, the first human insulin genetically engineered came into the market.
Sir, extremely sorry, sir, to interrupt you. Sir, you have 1 minute left, sir.
1 minute. So what I'll do is just run through the slide that this is the milestones of development. I will not touch about what insulins we presently have, because that is a workshop that will span over perhaps a week. But these are the different pharmacokinetic profiles that we have, and we need to titrate it to the choice of how and when we put the insulin in relation to food, exercise, and other stress habits, etc. The modern insulins, new generation insulin, and the oral insulin. What I like to stress here is that the ideal analogy to compare it with insulin in this is the world from clothing and fashion. Insulin has so many pleiotropic benefits. So insulin is and always will remain simple the way you actually design the whole curriculum for that. So it's the French, black dress with whatever you wear, wherever you're going. This will stand out as, as something wonderful, something eye-catching, something which is absolutely stunning. So insulin has to be adapted to nearly all occasions. And we know that these are the different varieties, and the deglutec has come in after glargine and detamere. And we have the glargine 300. We have the new fast-acting insulin aspart combined with niacinamide. So a little faster onset of action. The peak is achieved earlier with the elarginin. The stability is also more. Then we have also the ultra-rapid Glispro coming in from the Lilly's. It is also faster than the Fiasp. And we have, these are the vials, pens, syringes, the injectors, inhalers, patch pumps, and artificial pumps, and the next generations to come in. So the conclusion is, the reality is that insulin is the holy grail of diabetes management. The earlier ways can use this, the talking about glycemic legacy and a good positive metabolic memory, I think the better would be for the world. And we are still 100 years of insulin has been, after the discovery we have gone through. Yet how many people, we still talk about one dying in 6 seconds, 7 seconds, 8 seconds. Perhaps for insulinization, we need a very integrated team approach of diabetes educators, well trained. They can take it completely on a different stride. So my plea to the August delegates here and my fellow colleagues from the ESI, that all of us, all individual doctor who claim to practice diabetes as our passion, should all have one or two diabetes educators with us to share the burden of such a huge task of proper initiation is a big task, melting that ice, then optimization, and finally the intensification as and when it is required. So for that, please, as insulin remains the essential French, the black dress, we need also that beautiful, lady to wear that, a different dress to dress that individual patient with diabetes in a better way. Thank you, Anshuman, for giving me an opportunity.
Thank you very much, sir, for sharing the whole story behind this insulin. Now it's Dr. Shomi Goswami's turn. He doesn't require any introduction, actually. He is faculty at the Department of Endocrinology, University Medical College. He's Associated Editor of Indian Journal of Endocrinology and Metabolism. He's a Joint Secretary of Diabetic Association. So yeah, basically, for all of you information that almost 80 or 90 delegates are watching this our program now. So it's Dr. Shomi Goswami now. Please.
So thank you, sir, for that kind introduction. I'll start sharing my slides, and a very good evening to one and all. Are my slides visible? Are they visible, sir?
Yes, sir, it's visible. It's
okay,
visible.
Thank you.
Visible.
I begin with a small story. In 1498, we know that Vasco da Gama sailed to India, passing across the Cape of Good Hope at the southern tip of Africa. Now, this was something revolutionary because most sailors were afraid to sail south. They felt that they would fall off the edge of the earth. 20 years later, Ferdinand Magellan, another Portuguese, he made a 360-degree circumnavigation of the globe. This again was revolutionary. It only gave birth to the idea that the globe was round. There was no risk of falling across a flat earth. Now, today we might think these are simple ideas. People were very naive at that time. But this 360-degree circumnavigation actually made a paradigm shift in the way we viewed our world. In the last few years, there has been a sort of Ferdinand Magellan and Vasco da Gama effect in type 2 diabetes mellitus management. There has been a 360-degree paradigm shift, and I think it's high time that we accept and adopt these new guidelines in the management of type 2 diabetes. As was discussed by my previous speaker, just about 100 years ago, we discovered insulin, the first effective management for a 5,000-year-old disease. But it was only till about 20 years ago that we came to realize that we need to target something called the glycated hemoglobin in order to help our patients live better. But by living better, we only manage to improve their quality of life. Their quantity of life did increase to some extent, but cardiovascular disease was still occurring. The acute trial, the advanced trial, the VADT trial, HbA1c control, cardiovascular disease did not come under control. Rather, in the acute trial, there was an increase in mortality. Then again, if you look at the guidelines of that time, you see that it is an HbA1c centered approach. If you look at the ADA guidelines, at every step of the way, you have to look at the HbA1c and then decide on the next drug. Of course, it was a so-called cafeteria approach where you had 6 different classes of drugs to choose from. But then again, you chose them only to target the HbA1c. It was the be-all and end-all of management. You added one drug after the other. Depending on baseline comorbidities, mostly you had to look at the age, you had to look at coexisting cardiovascular disease to avoid hypoglycemia and avoid mortality. So it was more of avoiding mortality rather than increasing the duration of life that you were looking at, avoiding an adverse effect rather than preventing an adverse effect or preventing a bad cardiorenal outcome right from the beginning. Again, if you look at the AACE guideline, it was almost I would say a sort of reflection from the ADA guideline. There were HbA1c dependent cutoffs at different levels. And if you look at the SGLT2 inhibitors, they occupied third line or fourth line in the therapy after metformin. Now, this again is 2013. This was a time when the cardiovascular outcome trials with the SGLT2 inhibitors were still undergoing. They had not been published. And I think that the last couple of years, the biggest change that has occurred in the management of diabetes is with regard to the risk reduction in cardiovascular and renal risk that we look at right at the beginning. If you look at recent guidelines, these guidelines have changed drastically, and these changes have been effected on account of the so-called cardiovascular or the cardiorenal outcome trials over the last 5 to 6 years. And mind you, these trials are extremely expensive trials. To do a cardiovascular outcome trial would cost anything between 1,500 to 2,000 crore Indian rupees. But then again, they have enriched us to an extent which we haven't been enriched in the last 100 or several thousand years as regards the management of diabetes. You look at diabetes management across continents, management of heart disease in diabetes across continents, prevention or management of renal disease in diabetes in Europe, the European Renal Association, and you find that these trials have changed the way we look at diabetes. We look at the 2008 consensus statement after some of these cardiovascular outcome trials had been published. You find that the SGLT2 inhibitor group had now jumped a couple of steps up and were there right at the top along with GLP-1 receptor agonists after metformin as a second choice, as a second add-on therapy. Again, if you look at the ADA guidelines, yes, initially after metformin and lifestyle, you had to look at the HbA1c. But once the HbA1c was not controlled, it was no longer a cafeteria choice. There was a strict demarcation here. If you had atherosclerotic cardiovascular disease or chronic kidney disease, you had to go towards the right, where you used either an SGLT2 inhibitor or a GLP-1 receptor agonist. And if you had neither of these, then you went towards the other part of the guideline, where you again had a cafeteria choice of using any class of agents depending on your background risk of hypoglycemia, weight gain, or the cost involved. Now then again, if we just sum up what I've discussed over the last 6 to 7 minutes, initially, there was nothing. You merely reduced the blood glucose to avoid osmotic symptoms. Then came the UKPDS. We started targeting the HbA1c. In spite of targeting the HbA1c, we got some microvascular benefits, but hard macrovascular benefits, prolonging the duration of life, was still lacking. Rather, ACCORD trial showed increased mortality with strict HbA1c control. So SGLT2 inhibitor at that point of time, in the absence of cardiovascular outcome trials, was a third or fourth line agent. Then came the cardiovascular outcome trials and things changed actually. Now, after HbA1c, if you were not at good control of HbA1c, you had to look for underlying atherosclerotic cardiovascular disease or chronic kidney disease. And if you had it, you had to choose either an SGLT2 inhibitor or a GLP-1 receptor agonist, or possibly both of them, rather than the other therapies like DPP4 inhibitors, sulfonylureas, pioglitazone, or insulin, which were available, but which were no longer a preferred add-on after metformin in these group of patients. But then again, there was an important question still unanswered. Unless we are a cardiologist or a nephrologist or possibly an endocrinologist working at a tertiary care hospital, most of our patient population has high cardiovascular risk but does not have established cardiovascular disease or does not have established renal disease. So what happens to this big majority of diabetes with high cardiovascular risk? Do we again go back to that cafeteria choice? Or do we have something to offer them in terms of improving both their quality as well as their quantity of life? And this big change came in 2018. If you look at the AACE guidelines, the American Association of Clinical Endocrinology guidelines, which are very, very practically oriented, you now see that along with GLP-1 receptor agonist and SGLT2 inhibitor being high up there, right after metformin as the second add-on, they put in a line where they said not only in patients with established heart disease or established kidney disease, but even in those with high cardiovascular risk, you preferentially consider an SGLT2 inhibitor. If you look at the ADA position statement, there was a big change now. The ADA, after metformin and lifestyle modification, which remained the first line for all patients, moved to a non-glycated hemoglobin-based approach. After your patient was on metformin and lifestyle, you next looked at whether your patient had atherosclerotic cardiovascular disease, heart failure, chronic kidney disease, or most importantly, was even at a high risk of atherosclerotic cardiovascular disease. If any of these was fulfilled, you did not have to look at the HbA1c. The HbA1c could be 6.5, could be 7, could be 7.5. You chose between either an SGLT2 inhibitor or a GLP-1 receptor agonist, depending on what the case may be. So we see that the AAC includes high-risk patient, and the ADA now not only includes high-risk patient, but also asks us to not look at the HbA1c after metformin and lifestyle, rather look at whether they are high cardiovascular risk or established heart disease or heart failure or CKD. Make a choice. After that, if your HbA1c is still not controlled, you then have the other groups of agent to choose from. The European Society of Cardiology actually went a step further and said that, okay, if you are already on metformin, good enough. But if you are not on metformin and if you still have high cardiovascular risk or cardiovascular disease or kidney disease, you directly go to either an SGLT2 inhibitor or a GLP-1 receptor agonist without metformin. Again, this could be a matter of debate whether on metformin or without metformin you use these agents. What we need to discuss rather is why patients with even high cardiovascular risk were now considered in this protocol to be a person fit for an SGLT2 inhibitor. This change occurred on the heels of the publication of the DECLARE TIMI trial. If you look at the last 5 lines of this slide, the DECLARE TIMI trial included patients, men 55 years or more, women 60 years or more, with one additional risk factor. It could be dyslipidemia, it could be hypertension, or it could be tobacco use. And this population, the primary prevention, high cardiovascular risk population, formed the major chunk of 60% of patients enrolled in this trial. And if we just reflect back on our practice, we could even be a general practitioner, an endocrinologist, cardiologist, or nephrologist, or even a physician practicing diabetes. A major chunk of our patients, rather most of our patients, would fall in the group which was the primary prevention group in the DECLARE trial. Of course, the DECLARE trial showed that even in patients in the primary prevention cohort with high cardiovascular risk, use of dapagliflozin gives you compelling cardiorenal benefits compared to placebo. Now, what do the Indian guidelines tell us? The Indian guidelines, just like the Western guidelines, have accepted the strength of this cardiovascular and the cardiorenal trials. And they tell us that if your patient has established atherosclerotic cardiovascular disease, heart failure, or diabetic kidney disease, or is particularly obese and you need weight reduction, you do consider addition of an SGLT2 inhibitor right after metformin or right along with metformin if the HbA1c is say 8 to 8.5 to begin with. Again, even beyond these diabetes or cardiology societies, the European Renal Society now entered the ring. And they said that if your patient has an eGFR of less than 60, that is moderate renal disease, or has any degree of albuminuria, independent of the HbA1c, you add an SGLT2 inhibitor. And if you feel that adding an SGLT2 inhibitor would lead to hypoglycemia, you replace one of the existing oral anti-diabetic drug or insulin or anything as the case might be, depending on your clinical judgment, you replace it with an SGLT2 inhibitor because of the compelling renal benefits that were there in some of the published trials. So it was not only high CV risk, not only established atherosclerotic cardiovascular disease, but even an august renal society telling us that irrespective of HbA1c, if your patient is at high risk of renal disease, you start an SGLT2 inhibitor or even replace another drug with an SGLT2 inhibitor. The Canadian Cardiovascular Society was the first to jump onto the heart failure data, and they said that irrespective of the presence or absence of diabetes, in patients with heart failure with reduced ejection fraction, you consider the use of an SGLT2 inhibitor like dapagliflozin. And of course, we now know that this year in May, dapagliflozin received the FDA recommendation for use in heart failure with reduced ejection fraction with or without the presence of diabetes. Now, again, there are certain answers that we know, and there are certain answers that we do not know. We know that with the use of an SGLT2 inhibitor, we can prevent heart failure and we can treat heart failure. And we also know that it's closely related to renal protection. In fact, Dr. Subodh Verma, one of the pioneers in the field of SGLT2 inhibitors, strongly feels that some or most of the cardiac benefits, particularly the heart failure benefits, could even be primarily secondary to the renal benefits that are seen with these agents. We know that if we use these agents, the cardiac benefits, particularly the heart failure prevention benefits, kick in within days and weeks. We do not have to wait for months and years. We know that on top of good glycemic control, independent of blood glucose lowering, these agents give us cardiorenal benefits. That is the reason why, independent of HbA1c, the ADA asks us to use these agents in patients who need them. Independent of HbA1c, the European Renal Association asks us to use these agents in patients with compelling indications. There's an old saying that everything which counts cannot be counted, and everything which can be counted does not count. And this is another version of that slogan that you are seeing on your screen. But then again, we are inquisitive. We try to look at the etiology of what is happening, the etiopathogenesis of what is happening. At this point of time, we can exclude certain ways by which an SGLT2 inhibitor might help us. We know that the benefits that are seen are independent of blood glucose, blood pressure, or weight reduction. We know that the benefits are seen within days and weeks, unlike a statin, which causes plaque regression or stabilization over months. Yes, they do cause increased ketone oxidation, but that is one of the least beneficial roles that we know now. There are many other ways by which they benefit. And we know that if you use furosemide or torsemide in heart failure, you merely improve the quality of life. You do not reduce mortality. So it's something beyond the diuretic. Here we talk more of sustained natriuresis, differential diuresis, where there is a decrease in interstitial fluid volume rather than a decrease in the intravascular fluid volume. We know that use of an SGLT2 inhibitor leads to increased erythropoietin and downstream good effects subsequently. We know that they inhibit the sodium hydrogen exchanger. They inhibit the NLRP3 inflammasome, which is an anti-inflammatory effect of these agents. They provide ketone bodies as an additional fuel for the starving heart in heart failure. They reduce blood pressure without increasing the heart rate, hinting at a sympatho-inhibitory activity. And of course, as I discussed earlier, most of these benefits could still be secondary to the renal benefits that are seen very early with the use of these agents. Again, as clinicians, I think we are interested in the microscopic or the molecular mechanisms that are going on. But at the end of the day, we know that use of these agents in patients with established atherosclerotic cardiovascular disease prevents atherosclerotic cardiovascular disease. And we know that a drug like dapagliflozin, even in those without established cardiovascular disease but with high cardiovascular risk, prevents hospitalization for heart failure or the composite outcome of CV death and hospitalization for heart failure. With regard to the renal outcomes, again, I think these drugs are exciting in terms of the fact that beyond the RAS inhibitor, for a very, very long period of time, we had nothing to halt the progression of renal disease. But these drugs have now shown us that we have a potent agent to halt renal disease. I just have a couple of more slides. So finally, it all boils down to cost. So we know that these drugs are somewhat more expensive than, say, your common metformin or pioglitazone. But in diabetes, there's a term called cost effectiveness. We are running a marathon here and not a 100-meter sprint. So there are studies which have shown that it is more cost effective than a DPP-4 inhibitor. But again, you could say that in India, a DPP-4 inhibitor is available for as much a price as sulfonylurea. But even when compared to sulfonylureas, these are medicines which are more cost effective, because of the simple reason that if you could prevent these cardiorenal outcomes, if you could prevent a patient from going into dialysis, if you could prevent a patient from going into severe renal dysfunction and requiring 10 drugs at a time, if you could prevent a patient from going into heart failure, going into the ICU, requiring an ICD, requiring a defibrillator, and so on and so forth, your long-term cost, your overall cost actually comes down. There's a saying that an ounce of prevention is better than a pound of cure, or worth a pound of cure. I feel that an ounce of prevention is priceless. It's even more than a pound of cure. And the DECLARE TEAMMATE trial gives us confidence that use of dapagliflozin, even in a primary cardiovascular prevention setting, people with high cardiovascular risk, improves the quality as well as the quantity of life. Of course, if unfortunately you were to land into heart failure, it still gives you protection, it still prevents death, it still prevents hospitalization, and improves your quantity and quality of life. I think that I'll end there with the message that over the last 2 years, there has been a change in guidelines, and with the compelling cardiorenal benefits that we now have, the data that we have with SGLT2 inhibitor, it's time that we now become the Vasco da Gama and Ferdinand Magellan of diabetes management and adapt ourselves to the new data that we have with us. Thank you for your hearing.
Thank you very much, Dr. Shomik, for this nice deliberation. Here, it's another announcement, update that more than 90 almost delegates are watching into this program now. So now to explain the journey from DECLARE to the DAPA-HF again in an elaborated way, I would like to welcome the star of today's lectures, Professor Dr. Sunil Ghosh. He is the Secretary of Endocrine Society of India and Professor in Department of Endocrinology and Metabolism, IPG MER, SSKM Hospital, Kolkata. So here is Dr. Sujoy Ghosh.
Good evening, and thank you very much for those kind words of introduction. At the very outset, the first disclaimer is that this is a program sponsored by AstraZeneca, and therefore we are probably a little bit biased about talking about dapagliflozin. And I shall start off from where Shomik has left off. And one of the things that Shomik quite rightly pointed out is that cardiovascular outcome trials, though very, very expensive to conduct, have actually probably helped us to understand better and probably change the way we look at diabetes and the way we manage diabetes. Now, this entire history of cardiovascular outcome trials started with Steve Neeson's paper on rosiglitazone, which kind of suggested that people with diabetes were having excess cardiovascular events and mortality if they were treated with rosiglitazone. What happened thereafter, there have been successive meta-analyses to show that probably what Neeson said was wrong. But in the process, it led to the US FDA mandating that every drug that undergoes trial with anti-diabetic medication will have to prove that the drug is safe. So the cardiovascular outcome trials essentially were meant to show that the drugs were safe. I think when the initial trials were done, nobody even thought of that these group of drugs are actually going to give us cardiovascular benefits or cardiovascular superiority. The other thing, if you look at the endpoints of cardiovascular outcome trials that were made, was predominantly a conglomeration of a few things. The so-called 3-point MACE, included fatal cardiovascular events, non-fatal strokes, and non-fatal myocardial infarctions. Now, what at that point of time we as clinicians failed to understand was perhaps the importance of heart failure in diabetes. I think in recent times we've understood that just like atherosclerotic cardiovascular events are important outcomes in management of type 2 diabetes, heart failure itself is a big problem, more so in diabetic individuals, and of course also a problem in non-diabetic individuals. And Shomik has also talked about, DAPA as in the management of heart failure as in declared TIMI. And I'll just go back and recap of what has happened in the world of heart failure before I go into the DAPA heart failure study. Now, this is the paradigm heart failure study with ARNI, that is sacubitril with valsartan, compared with enalapril, which suggests that there's almost a 20% reduction in the risk of cardiovascular events if you use ARNI compared to enalapril, whether the individual is diabetic or not. But what is important to understand is, just like when you're talking about statins or any other drug, whatever risk reduction we are talking about is relative risk reduction. But even after that relative risk reduction, there is some amount of residual risk. So for this study, for example, you can see there's a significant amount of residual risk, even if you're treating an individual with an ARNI. And Shomik spoke about a lot of the underlying pathophysiological mechanisms. As you can see in this particular slide, there are certain pathophysiological mechanisms which are common both to diabetes and heart failure, including endothelial dysfunction, myocardial dysfunction, activation of the RAS, and inflammation. So if you have underlying common pathophysiological mechanisms, it's likely that some of the drugs that we use, if they target both of these underlying pathophysiological mechanisms, they will benefit not only patients with diabetes, but also benefit. And the other thing that we've understood is, just like when we look at glycemia, which is a spectrum disorder, heart failure itself is also a spectrum disorder. So you can have individuals who will have subclinical heart failure, then they will move to the stage of clinical heart failure, and then gradually overt heart failure, NYHA class 1, 2, 3, and 4, and ultimately end up in end-stage heart failure. So if you recap, the data that Shomik showed from declared TIMI were people who were not necessarily people who had overt heart failure. And yet, if you look at the outcome data of declared TIMI, you can see new onset heart failure and hospitalization due to heart failure was prevented. So you had what Shomik pointed out was prevention of heart failure or prevention of progression of heart failure from the declared TIMI study. And I will show you from the DAPA heart failure study that individuals who already have established heart failure, how do they fare when you use an SGLT2 inhibitor, in this case, dapagliflozin. So if you look at all those individuals that we are talking about in the preclinical stage and clinical stages of heart failure, we now have 3 clinical trials that have been published, and one with canagliflozin, that's the CANVAS program, dapagliflozin, that's the declared TIMI, and empagliflozin, that's the EMPA-REG outcome. Now you've got to remember that all of these studies, hospitalization due to heart failure was primarily a secondary endpoint or an exploratory endpoint, not a primary endpoint. These were not heart failure trials. These were hardcore cardiovascular outcome trials, predominantly looking at cardiovascular events, not heart failure, but all of them had evidence to tell us that heart failure was getting prevented, hospitalization due to heart failure was getting prevented. If you look at, on the other hand, individuals with established heart failure, you have studies like DAPA-HF and EMPEROR reduced, which have already been published. The others are still underway and will get published in the near future. And if you look at heart failure and SGLT2s, we've got to know what's the efficacy in individuals with heart failure with reduced ejection fraction. with these group of drugs? And are these group of drugs beneficial in patients with heart failure with or without diabetes? What happens to the side effects, which we are all concerned about? What about quality of life? And particularly if you're using it in individuals without diabetes, do these individuals land up with hypoglycemia and diabetic ketoacidosis? And where do you position these group of drugs in the management of heart failure? So coming to the study per se, we will look at the DAPA-HF heart failure data to try and see, can this group of drug, namely dapagliflozin, be used now to treat people with established heart failure? Can they be used in individuals even if they don't have diabetes? And can they be used in individuals with reduced ejection fraction heart failure? With regards to those with preserved ejection fraction heart failure, we have trials underway which will answer the question some point of time in the near future. So if you look at the trial design of DAPA heart failure, it's a pretty big study with almost 4,500 to 5,000 individuals, adults with or without diabetes. These are individuals with reduced ejection fraction heart failure, NYHA class 2 to class 4, with ejection fractions less than 40%, elevated NT-proBNP. Their renal function, the eGFR was more than 30, and these were individuals who were on stable standard of care treatment of reduced ejection fraction heart failure. So these were not suboptimally treated. So people who needed beta blockers, they were on beta blockers, ACE inhibitors, ARBs, ARNIs, mineralocorticoid receptor antagonists, ivabranine, people who needed whatever they needed, they were on it. And the primary endpoint was time to first occurrence of any of the components of the composite of CV death or hospitalization due to heart failure or an urgent hospital visit for heart failure. And the secondary endpoints, time to first occurrence of either of the components of composite of heart failure, hospitalization or CV death, the total number of hospitalization, either first event or recurrent for hospitalization due to heart failure, CV death, and also change from baseline measured at 8 months in the total symptom score of the Kansas City Cardiomyopathy Questionnaire, time to first occurrence of any of the components of renal outcomes, and time to death for any cause. And if you look at the baseline characteristics, these were elderly individuals above 60, age, predominantly males, and you can see the breakup. Most people in NHA class 2 and class 3, predominantly class 2. So, and if you look at ejection fraction, it's around 30. They had very high NT-proBNP, systolic blood pressure reasonable. Most of these individuals had ischemic etiology, heart failure, reduced ejection fraction heart failure. Renal functions not that bad with an eGFR around 66. And more than 50% of the individual did not have diabetes. Only 45% had diabetes. So we are now looking at managing patients with heart failure beyond the history of diabetes. And if you look at the treatment background that these individuals had, they were on standard of care for management of heart failure. You've got to remember that this trial was started at a time earlier to the emperor reduced and the emperor preserved heart failure. Therefore, about 10% of the individuals were on ARNI. Subsequent studies, as you can see, will have more people on ARNI, and a significant proportion are on mineralocorticoid inhibitors. They were on optimal RAS blockade, and where needed, they were on digitalis and beta blockers. In terms of the anti-diabetic agents, they were on standard anti-diabetic agents for their management of diabetes in the background in the individuals who are diabetic. And if you look at in the outcomes of the DAPA heart failure study, you can see, if you look at the first outcome, that is the cardiovascular death, hospitalization due to heart failure, or urgent heart failure visit to the hospital, you can see almost a 26% reduction in that composite outcome. Now, if you look at the breakup of those individual composite outcomes, first let us look at either hospitalization for heart failure or urgent heart failure treatment or visit to the hospital. it's a 30% reduction. Hospitalization due to heart failure, again a 30% reduction. A significant 18% reduction in cardiovascular death. And if you look at cardiovascular death or hospitalization due to heart failure, again a significant reduction. And all-cause mortality, a significant 17% reduction. You know, there can be no greater treatment outcome for a doctor to look at than deaths. You know, everything else can be controversial in terms of outcome. A death prevented is a death prevented. There can be no controversy about reduction of cardiovascular death or prevention of death from any cause. So this, as you can see, is something that the DAPA heart failure study showed, something which the Emperor Reduce failed to show, but that's probably because of the difference in the study design. And if you look at now, was these events driven by the people who were diabetic versus the non-diabetic? Let us look at subgroup analysis. Like I've mentioned before, 55% of the individuals did not have diabetes and 45% of the individuals had diabetes. And in terms of the primary composite endpoint, there is absolutely no difference in the outcome, whether you had diabetes or whether you did not have diabetes. If you had heart failure, reduced ejection fraction, you had equal benefits with dapagliflozin. And if you look at the ones who did not have diabetes, and if you look at even the ones who had pre-diabetes, they had the same kind of benefit. So across the board, irrespective of your glycemic status, you did well in terms of the heart failure benefit. Now, could some of the background treatment have made a difference in terms of the anti-diabetic drugs? Whatever anti-diabetic drugs you were on in terms of the glucose lowering therapy, whether you were on metformin, whether you were on sulfonylurea, whether you were on insulin, whether you were on DPP-4 inhibitor, whether you were on any combination therapy, the patients did identically well in terms of the cardiovascular heart failure benefit. In terms of the baseline A1C, the non-diabetic individuals, obviously the diabetic individuals had glucose lowering, which was better, but the non-diabetic individuals did not have any significant or dramatic lowering of HbA1c. The weight benefit was equal in both groups. The blood pressure lowering, the renoprotective benefit was equal in both groups. And there was similar change in hematocrit in both groups, some degree of hemoconcentration, which is probably one of the mechanisms that Shomik was talking about. In terms of the safety outcomes, because that's something that we are all worried about, there is no difference in the serious adverse events or any adverse events in both groups by diabetes status, whether you had diabetes or whether you did not have diabetes. What about the renal benefit? One of the things that we were talking about was, is it the renal benefit which drives the cardiovascular benefit? Irrespective of your baseline renal function, the patients did well, because that's quite reassuring. Because individuals who had an EGFR greater than 60 versus those who had a less than 60, they benefited equally well. Because we know particularly individuals with bad kidneys tend to do bad when it comes to heart failure. So this study result is reassuring to tell us that even if you had bad kidneys, your heart failure benefit with the drug was identical to people with relatively better kidneys. And that holds good for the CV death benefit, the hospitalization due to heart failure benefit, or all-cause mortality benefit. And even the safety outcomes were similar, whether you had good kidney function or whether you had bad kidney function. What about analysis on the basis of age? As you can see, there's quite a wide range of individuals. Particularly, you have a significant proportion of people who are elderly. Now, the elderly people we are more worried about and more concerned about because of two reasons. Number one, we are worried that they might have more side effects, particularly postural hypotension, dizziness, and the genitourinary problem. And the second thing is, we know that in diabetes, one of the major determinants of complications is duration of disease. So is the duration of disease going to make a difference in the outcome, in the prevention of these complications? So if you look at, irrespective of the age, the primary outcome benefit was identical across the board in terms of the age. in terms of the CV death benefit, in terms of the hospitalization due to heart failure benefit, in terms of all-cause mortality, and in terms of the serious adverse event also, there seems to be no difference according to the age distribution of the individuals. What about individuals on the basis of systolic blood pressure and BMI? The reason this analysis is important is because if you think in individuals with heart failure, one of the things that we are worried about is whatever form of therapy we are giving, are we lowering the blood pressure to a certain extent that will cause underfilling of the heart and cause hypotension and worsening of cardiovascular activity of the heart. So for example, we are worried to say, for example, giving a diuretic or an ACE inhibitor if the blood pressure is too low. So here you can see, irrespective of your starting systolic blood pressure, the cardiovascular benefit of heart failure seems to be identical irrespective of your starting systolic blood pressure. In terms of the BMI, again, individuals seem to do equally well across the board because we know obese individuals usually tend to have worse outcomes in terms of heart failure. So in terms of the background therapy, you might say, you know, some people had ARNI, therefore, do they benefit similar to individuals who are not on ARNI? Because that's the other major development that has happened in the world of heart failure management. So here you can see, even though the numbers are not that big, that whether you were treated with ARNI or not treated with ARNI, the effect of an SGLT2 dapagliflozin was equally good in both of these group of patients, telling us that you can use this group of drug over and above ARNI in the management of heart failure, whether you're diabetic or not. And in terms of individuals with diuretics, because a lot of people think that, you know, because this group can be looked at as a group of people where there is some amount of volume change because of the interstitial volume change, there is some amount of volume depletion, but that does not lead to postural hypotension or cardiovascular events that you are normally associated with volume depletion. And again, the overall safety remains same whether you are on placebo or dapagliflozin in terms of the renal outcome and volume depletion. Fractures and amputation, something that was signaled as possible side effects of SGLT2 at one point of time, is something that can probably be laid to rest at this point of time. Major hypoglycemia and diabetic ketoacidosis is also not a problem in this group. So if you look at the current management of heart failure treatment, you have had 4 groups of drugs that have probably made a big difference to the management of heart failure. One is ivabradine, which controls heart rate and improves outcome in heart failure. The second is eplerenone, which is the same group as spironolactone, which has helped in the management of heart failure. The third is the ARNIs, and now you have a 4th group of drug that is dapagliflozin as an SGLT2 inhibitor for the management of heart failure. So if you look at the European guidelines of 2016, there you can see you had these 3 groups of drugs, apart from the ACE inhibitor, beta blocker, and angiotensin receptor antagonist. That is one group talking about ARNI, one group talking about ivabradine, and the other group talking about CRT, depending on where you fell. For example, I talked about the rhythm problem. Ivabradine would have been given if the heart rate is high. If individuals were tolerating ACE inhibitor, you were replacing the ACE inhibitor with an ARNI. And if there was a rhythm problem, you would go for chronotherapy. Now, from there on, now we have moved on to another paradigm shift in the management of heart failure, irrespective of whether you have diabetes or not, is the addition of SGLT2 inhibitors. Currently, we have evidence from dapagliflozin, both in the prevention of heart failure, that is from the DECLARE-TIMI study, and now in the management of heart failure, that is from the DAPA-CKD study. I shall stop there for any questions. Thank you very much.
Thank you very much, Professor Ghosh, for this detailed and extensive explanation of DAPA-HF study. Now we have a long-awaited panel discussions, actually. And for that, I'd like to request to moderate this panel discussion, Dr. Shomi Goswami. Dr. Goswami, the floor is yours. Dr. Goswami, you are muted.
Okay. A very good evening again. Since we are late, I think we'll keep the discussion crisp. We already have heard from Dr. Kaushik Vishwas, from Dr. Sujoy Ghosh, myself, and I think I'll invite some of our elite panelists to the panel. We have with us Dr. Debashish Choudhury, who is the Deputy Director of ESI West Bengal. Welcome to the panel, sir. We have Dr. Dilip Shahu, who is the Medical Superintendent of ESI Bhubaneswar. Dr. Shahu, welcome to the panel. We have Dr. Deepak Gupta from ESI Jamshedpur, a respected consultant from ESI Jamshedpur. Welcome, Dr. Gupta.
Thank you.
And we have Dr. Pradyum Kumar Singh, a consultant from ESI Jamshedpur. Welcome, Dr. Singh.
Thank you.
I think we have a couple of questions which we'll first direct to the speakers before we go on to our elite panel from ESI. We have a question as to the role of SGLT2 inhibitor in COVID-19. Dr. Partho Chattopadhyay has this query, and I think Dr. Kaushik Vishwas would be the best person to answer this. Role of gliflozins in COVID-19. You have touched upon the topic. A crisp answer once more. Dr. Kaushik Vishwas?
Kaushik, unmute yourself.
Yeah, thank you, sir. See, as I discussed during my presentation, that SGLT2 inhibitors are better be discontinued in patients when infected with SARS-CoV-2 because of the possibility of development of hypotension, electrolyte imbalances, and euglycemic ketoacidosis. But there's a trial is going on known as DN19 in patients who are hospitalized with dapagliflozin. I don't know. The results are yet to be published. It's a controversial trial. However, from the practical point of view, it's better to discontinue SGLT2 inhibitor in patients with COVID-19, especially if they are moderately symptomatic or definitely in severely symptomatic patient.
Thank you, Dr. Vishwas. I think Professor Ghosh has something to add to this.
I think what Kaushik has said right now is the thing to do, to try and discontinue SGLT2 inhibitor whenever in doubt that this individual might be developing COVID or follow standard sick day rules. With regards to the DARE-19 study, AMRI Hospital Dhakuria is one and only site in India, in Eastern India, which is doing the trial. I'm the primary investigator of that particular trial in Eastern India. I'll just try and give a background. Please don't start using it. But the fact is, one of the major proposed pathophysiological mechanisms of complications of COVID-19 is basically vasculopathy. You have individuals who are developing myocarditis, stroke, renal dysfunction. And we have seen with the DAPA-CKD and the DAPA-HF study that these complications of vasculopathy might probably be improved with the use of SGLT2 inhibitors. So that's the logic. And this study is going on in the United States, Brazil, and United Kingdom as well. We already have enrolled more than 900 patients. And the first bit of preliminary analysis has been done and the results are encouraging. But as of now, as clinicians, please to stick to what Kaushik has.
Sorry, you have.
Do not use SGLT2 inhibitor in individuals who are suspected to have COVID.
Thank you, Dr. Kaushik and Professor Ghosh. I just have a small addition and an apology to make. Dr. Debashish Basu is also there with us in the panel, and I think since he is the mentor and pioneer of DAY, he has to be there. And my apologies for missing out on his name. And I have a question for him right away. The question is not related to insulin, but rather related to SGLT2 inhibitor. And with his experience, I think he will help us get to the answer. The question is, when patients are well controlled with current treatment of DPP-4 and metformin sulfonylurea combination, is there a requirement of adding another drug like SGLT2 inhibitor in these patients? And this question comes from Dr. Paromita Gupta, because it will increase the pill burden. So if a patient is well controlled on 3 drugs, when do you use an SGLT2 inhibitor? Dr. Debashish Basu, please.
দেবাশিস দা আনমিউট করতে হবে।
Sir, please unmute.
So, as you have already elucidated on those points of the present guidelines, the clinical indication and which setting do we want to write this? I mean, if we admit that diabetes is a cardiovascular disease, whether established or not, then perhaps, as Dr. Professor Ghosh has already said, that whether you have diabetes or not, you can, in a case setting of DAPA, in a setting of heart failure, DAPA can be a good choice. Similarly, I would look at from a different angle and say, if you have diabetes, let us assume that you have some kind of element of heart problems, whether it's a coronary plaque, stable or unstable, whether it's an impending heart failure, whatever it is. I mean, an SGLT2 at this hour, if it is affordable, perhaps would be a good choice. But again, if you are talking about 2-3 molecules which have already been given, in the full promise of it, and the merit has actually given you the desired result of your A1C and the other parameters correction, and you are doing well, the quality of life and the quantity of life all are assured, then I don't think it is necessary at this point to add a very costly molecule in order to kind of put that pill burden. But now the point is, now I think we are getting 1 or 2, 3 all these salts put together in one capsule, and like a polypill it might come, but it's very difficult. The PK would be different, the PK would be different. So the thing is, as you said, that an SGLT2 inhibitor, I'm a very big fan of SGLT2. I have an association or an attachment with a private hospital as well, where I have been able to write that 300 milligram gliflozin, and I've seen quite remarkable results. And I think the paper, they're kind of coming up with good data from that paper. And if from all the pleiotropic arms as well, I mean, from the liver fat point of view, from uric acid point of view, and of course, the main glycemic part and the cardiovascular protection part. So I would definitely, I'm a big fan of SGLT2 inhibitor, but for the general mass, when we're talking to the overall crowd in the country, I think if you're managing well with, say, vildagliptin and metformin, whatever kind of a fallout of the Verify trial, if that is taking you at the primary care level, even at the primary prevention, where DAPA has, taken a major step. These are the things that you need to rationalize looking at the patient. So how much is he going to get the benefit from? How much can he pay? Is he paying through his nose? And then, the quality of life is gone from that point of view. These are the things that need to, ascribe to.
So thank you, Dr. Debashish Basu, for that very detailed answer, and of course, sharing your personal experience as well. And I think that also answers Dr. Debashish Mukherjee's question to some extent, who asked us if there's a slight elevation in HbA1c, when would you use an SGLT2 inhibitor? So I think in short, if there is a compelling benefit, you can use an SGLT2 inhibitor. And of course, we now have DPP-4 inhibitor, SGLT2 inhibitor combinations like dapagliflozin, saxagliptin, or empagliflozin, linagliptin, which would take care of the pill burden as well. I think that we are privileged to have amongst us the administrators of ESI. We know that workers are the backbone of any nation, and ESI keeps this backbone erect, keeps this backbone healthy. So I think we will ask Dr. Debashish Choudhury first, and then Dr. Dilip Shahu, to enlighten us on how do you select a drug in your formulary, because that's a very big choice that you are making. You are influencing crores of lives and influencing the health of the nation as a whole. So when you are thinking of including a drug in your formulary, what do you look at in that agent? First, Dr. Debashish Choudhury, please, if you could enlighten us.
Good evening, everybody. Myself, Dr. Debashish Choudhury. Firstly, I thank AstraZeneca and Day for organizing such a beautiful webinar. And I must thank Dr. Basu, Dr. Vishwas, Dr. Goswami, and Professor Ghosh for such a beautiful delivery of the subject. What I am telling you, I am listening to these things, and as you have told, that we are a very big work. We have very big workforce, and in West Bengal, we have 20 lakh IPs. We are catering to these IPs, insured person. That means if you on an average, because they include their parents also, we include their parents also, on an average 5 per family. So we are treating nearly 1 crore people in West Bengal only. So I am thinking that out of this 1 crore people, we are giving them primary care, secondary care, and tertiary care, and so many people are diabetic. So many people are diabetic, and we in ESI, there is no such medicine which we are not giving to these patients. Every medicine, starting from metformin to pioglitazone to Saxa, Sita, Vilda, Cana, Dapa, everything we are giving. But what I am thinking that these patient base, they are fixed. I mean, what do I mean to say? That these patients are coming to our hospitals. There is a huge data we can collect from them. Why don't we, the doctors of ESI who are listening to this, why don't we give a trial on these medicines? Because we have beautiful labs in all our ESI hospitals. Any test we can do, any medicine we can prescribe, everything we can prescribe, and there is a huge data. And these patients, they are regularly coming to our hospital to get the medicine. So there is a huge number of data we can collect. And as you have told, I am listening to those that this such and such trial is going on, and mostly of not only of India or West Bengal, it is from outside countries. So we have a very significant data we can generate from these people. So to my, I can ask you to give it a thought. Why don't we give a trial of these medicines? Because this is a tropical country, and these patients are working in the factories, and mostly in the factories. So we are seeing that many there is a gradual increase of renal failure, and every day we are giving patients dialysis, and it is increasing day by day. So if we can give a trial of DRAPA or whatever medicine maybe for the diabetes, so that which will be beneficial to these IPs, so that these IPs or insured person can go to the factories disease free or limited with the prescription or drugs. And we are giving all medicines, any medicine you name, we have it. Everything. ESI Corporation has told that IPs is our VIP. We will give them any medicine, whatever is required. So I think there should be a trial in this type of on our behalf by ESI, and someone of you may guide them also. Thank you.
Thank you, Dr. Chaudhuri, for giving your perspective, and of course the importance of research generating our own data. That is something very important which you highlighted. And I think that if the Astra medical team or the people are listening, you spoke of generating data with dapagliflozin in India. I think they've taken note of that as well. Now, Dr. Dilip Sahu, I would ask you the same question. You are in an important administrative post. You are the superintendent at ESI Bhubaneswar. So when you think of putting in a drug in your hospital formulary, your hospital pharmacy, what are the things that you keep in mind? How do you decide on which drug will be available and which will not be available? Dr. Dilip Sahu.
Basically, myself, I'm just telling all of you. Myself, Dr. Dilip Sahu. Basically, I'm practicing ophthalmology I'm an ophthalmologist. I used to practice ophthalmology since last 30 years. Previously, I don't used to see so much of diabetic, diabetic retinopathy. What I mean to say, diabetic retinopathy incidence and the blind incidence has increased nowadays because of irregular and quackery use of the drugs. So it should be used very scientifically. In the past, in the 1989, 99, I used to do post-graduation study. We have no choice, only biguanides, that is metformin. And other is your other drug is your sulfonylureas. And nothing was available. Connection, yes. Then what nowadays, I'm happy that people have come up with so many SGP2 inhibitor, DAPA, and gliptins, and with less side effects. But one thing I'm observing, previously, people, I think this is their lack of exercise and lot of burdens and lot of stress and your fast food. These are causing and heredity diabetes. These are responsible for increase in the diabetic load. I think so. Previously, we didn't so much of retinopathy. Now, I'm seeing more ophthalmic field. Whenever it is coming, is retinal bleeding, subretinal bleeding, vitreous hemorrhage. These are very common. So I always prefer oral anti-diabetic is always better than insulins, because insulins, the IPs has to carry with them, and you have to take at the proper time. There is hypostatic, what you call the orthostatic hypoglycemia, which does not occur with DAPA. One thing is DAPA is doing, that is mild to moderate United infection. That with good glycemic control, with good perineal hygiene, it will disappear. But still, it has a chance of doing little orthostatic hypotension and these UTI infections. Except that the drug is excellent. Our professors have told it is a marathon. So in a marathon, it is a cost effective. It's not that effective. Where other insulins and our the other insulins are very costly in compared to cost effectiveness. And a respective patient can carry very well in home. In our hospital, we used to treat 5 lakh patients. Every one day OPD, you just lot of diabetic patients. So you are overloaded with diabetic patients with complications, with retinopathy, with nephropathy, with CKD, with cardiomyopathy, with neuropathy, whatever it may be. So I think that DAPA is a good drug, in my opinion. Whatever may be, DAPA is doing well, and gliptins have come out. But but something counseling must be there. I want to. We must counsel the patient regarding the change the lifestyle, which is most important. We have to change the lifestyle. Without lifestyle changing, only drugs cannot help. Thank you.
Thank you, sir, for sharing your valuable insight. Now I'll move over to Dr. Deepak Gupta, who is a renowned consultant from ESI Hospital, Jamshedpur. And I have a very important question for him. We have looked at how a drug, SGLT2 inhibitor, could act in a patient with high CV risk to prevent cardiac outcomes and renal outcomes, as well as in patients with established heart disease and renal failure. So since you are a busy practitioner, you look at a large number of patients at the OPD. In your practice at ESI Hospital, what proportion of patients with diabetes would fall into this high CV risk category, would fall into established atherosclerotic cardiovascular risk category, would fall into this mild to moderate renal disease category, and what proportion would have none of these, would be absolutely fine without a single comorbidity in type 2 diabetes, obviously. Dr. Deepak Gupta, if you could share your experience, please.
Sure. Am I audible?
Yes, you're audible, Dr. Gupta.
Yeah, sure. Actually, in our hospital, we are having a center of excellence for diabetes with the help of AstraZeneca. And we are capturing the data, as Dr. Devashish asked that in ESI, it must be somebody must do the data capturing, and we are already doing that. And to give you a data, I'm giving you a pre-COVID lockdown data actually. We had from ESI Jamshedpur, we had around 474 patients, if I remember correctly, diabetic patient, type 2 diabetic patient, out of which 112 were the cardiac patients, the cardio-diabetic patients. They established they had either had a bypass or a stent or TMT positive. Out of that, 52 patients were the CKD stage 5 who were undergoing the dialysis, the regular dialysis. The 71 patients, or 70 or to 75, I don't remember exactly, were the stage 3, I mean the CKD stage 3 patients. Now we are just capturing the data actually, and the basis by which we go to treat these patients is we have in the Center of Excellence for Diabetes. Whenever the patient comes to our facility, first of all, we take the proper history. The diabetic educator is there. He takes the proper history. We do a ACVD risk calculation by the app-based calculation with the sex, the cholesterol, HDL, and everything. And based on that and the other the reports, the ECGs and the blood reports, we start the patient on a metformin if it is not contraindicated, and we generally follow the protocol of the ADA guidelines, the ASCVD predominant or the heart failure CKD predominant patients in our group and the other groups. And that's how we go. With regards to the percentage of the patient, since our data capturing is still going on, we really can't much, I can't really much comment on that. But approximately 50% of our patients, type 2 diabetic patients, are having a complication. And of the 50% of the patients, 50% of the patients are either the CKD patients or the heart failure patients, and like that.
So thank you. And I think that gives us a very nice insight, since you spoke of the number who are already on dialysis and who are in stage 3, stage 4 CKD. It seems almost 1 out of every 3 patients in your cohort, or 1 out of every 4 patients has moderate to advanced CKD. At the same time, there's a lot of cardiac disease. And I think when you have atherosclerotic cardiac disease and CKD, a lot of underlying heart failure, diagnosed or undiagnosed, must also be there. So in this perspective, given the fact that you are dealing with a very high risk population, how would you place an SGLT2 inhibitor, say particularly a drug like dapagliflozin, with all the data that you have, in treating the cohort that you are looking at, in its preventive aspect mainly, since you already have a lot of renal disease established? I think you would like to prevent it in the rest of your cohort.
Right, definitely. The thing is, with regards to how much we are able to prevent it, how many patients from CKD 3 are we are able to prevent from 3 to 4 to 4 to 5. That will be the data driven, and which will be maybe after a year or so I will be able to comment more on that. But as of now, as I said, we follow the ADA guidelines, and after the metformin, we definitely give the SGLT2 because the money is not a constraint for us, and the GLP-1 analog is also available with us free of cost to the patient. So we are very, I'm very privileged to work in ESI, where at least I and the patients don't have to worry about the cost factor, and the GLP-1 and the SGLT2 and as well as the DPP-4, whenever it was costly, the DPP-4, they all are available to our armory for the treatment of the patient. So the SGLT2 inhibitor are definitely, after metformin, they are the first line drugs as far as the diabetic treatment is concerned to our patients, if not contraindicated.
And do you follow the high CV risk population as well in terms of adding an SGLT2 inhibitor with data like from the declared TIMI, when you don't have established either heart disease or renal disease, but there is a risk of progressing to heart failure or heart disease?
Right. Yeah. With the data which has come just few months back, where the left ventricular ejection fraction was less than 45, and the debate is more about whether the DEPA is the medicine for cardiologists or endocrinologists. So with that, we are definitely giving the Forxiga, or rather the dapagliflozin or the SGLT2 inhibitor in particular.
Thank you. I'd just like to interrupt you. Like, we in heart failure, drugs have a role. SGLT2 inhibitors, established heart failure. In established moderate kidney disease, they have a role. I'm talking of the primary prevention cohort, the high CV risk cohort. Do you consider them to be candidates for an SGLT2 inhibitor, given the data that we have from the declared TIMI trial? Does that population also fit into your criteria?
From last 2 months, they have started fitting in my criteria now. I can say that.
Okay.
After the
Okay, because
data.
the thing is that
The
our
more,
ambit has increased in the last 2 years after this high CV risk has been included also. So I think more proportion of patients are being covered nowadays. That is what I was wanting to know from you, because Jamshedpur is an area where we don't have an idea, ESI Jamshedpur, as to what proportion of patients are going there with the cardiorenal risk factors. Dr. Singh, Pradyum Singh, if you could just add a line or two to what you think about use of SGLT2 inhibitors in the population that you see in your OPD practice. Just a brief comment, please.
I am originally an orthopedician, but
okay.
I think here the store in charge. And regarding this, Dr. Deepak, what Dr. Deepak advice we provide him from the store.
So
nothing.
Okay, thank you. But I think that you are in privileged company, because as Dr. Debashish Basu told us, even Dr. Banting was an orthopedician and he discovered insulin. So anyway,
I was just about to tell him that. Absolutely.
Jokes apart, I think we'll have a final question now for Dr. Sujoy Ghosh, Professor Sujoy Ghosh. Is he here with us? Okay. So, Professor Ghosh, final comment. In which category of patients would you definitely use an SGLT2 inhibitor? And of course, what are the precautions that you would take before using an SGLT2 inhibitor? The pros and cons, your final comment, please, Professor Ghosh.
I think one of the points that was being made is, probably this was a drug that endocrinologists and diabetologists were predominantly using. And as you were pointing out, Shomik, that the ambit has increased. So if I look at individuals with diabetes and individuals without diabetes. So if I look at individuals with diabetes, the European cardiology guideline has gone to a step that this becomes the first line drug. SGLT2 or GLP-1 becomes the first line drug even before metformin. I'm not going there. I think it'll take some time before we go there. So I'm assuming an individual with type 2 diabetes, lifestyle modification, diet, exercise, and metformin. That's done. Thereafter, if I'm choosing the next drug, as you have stated, look at the ASCVD, renal outcomes or renal problems, and heart failure. In the ASCVD, if you already have established ASCVD, there is no doubt. There is established heart failure, there is no doubt.
Hi doc, please mute everyone.
If there is established renal disease, add an SGLT2 inhibitor, there is no doubt. High risk cardiovascular patient, the point that you were trying to make in primary prevention, that is there in now the guidelines, but still, depending on your cost benefit ratio, because here we are talking about ESI dispersing the funds, but in your practice and my practice, that might not be the case. So in primary prevention, probably we will have to think of the cost as well. If cost is not an issue and the side effects are not an issue, then it's fine. Use it there as well. Individuals where hypoglycemia is an issue, where weight management is an issue, and cost is not an issue, there also a second line drug would be an SGLT2 inhibitor. Now, if I look at individuals without diabetes, there, if you have established heart failure, and if you think that you have gone with the standard of care, that is salt restriction, fluid balance, used a beta blocker, you gone for RAS blockade, used an ARNI or even a mineralocorticoid receptor, and then you think that you need something else on board, think of an SGLT2 inhibitor. In terms of non-diabetic individuals also, if you are having someone who's got some degree of renal dysfunction and you want to prevent poor renal outcomes, use an SGLT2 inhibitor like dapagliflozin. I understand it is still not licensed for it, but the DAPA-CKD data, as far as I am concerned, is convincing enough. The credence data is convincing enough for me to understand that the SGLT2 group of drugs will probably do well in the renal protection. In terms of the practical tips of when to use, how to use, and when not to use, one obviously cost is a contraindication in a lot of our patients. That's one of the issues. We have to spend some time with the patient. This is not a DPP-4 inhibitor which you just prescribe and say, "Ye lijiye prescription, leke jaiye dawai." You have to tell the patient about the precautions that he takes. You have to educate the patient about things that he needs to do in terms of genital hygiene. That is probably the most important thing. Secondly, please do not give it to an individual where you are suspecting severe degree of insulinopenia. Anybody who is taking the drug, try to teach him the basics of a sick day rules. You know, you're having severe diarrhea, you are going to undergo surgery, or wherever in doubt, for example, here in the COVID scenario, please do not use the drug. Good genital hygiene, very important. If you are able to do these things in terms of the basic education, spend a little time, because for this drug, you have to spend that few more minutes, 2 to 3 more minutes. Maybe for someone or an organization like ESI, it might be even useful if they print out leaflets of education in the languages that people will understand. Along with the prescription, even from the pharmacy that is handed out, I think it's going to be beneficial. And I think when you find cardiologists saying a drug is good, nephrologists saying a drug is good, of a drug that a diabetologist and endocrinologist uses, I think it must be a good drug because they are more intelligent than us.
So thank you, Professor Ghosh, for that witty remark and of course that scintillating summary of use of SGLT2 inhibitors. I think the SGLT2 inhibitors are a group of drugs which have more pros than cons. Of course, some cons are there, as you rightly mentioned. And I think that with all the published evidence, we are increasingly using this to improve both the quality and quantity of life of our patients. With that, I end this panel discussion and thank all the panelists for putting in their valuable thoughts and sparing their time for this discussion. Thank you. Over to the organizers for the vote of thanks. Dr. Basu has something to say. Yes, Dr. Basu.
No, I think Ongshuman, are you there? Who is doing the vote of thanks?
I'm there. Indrajit will convey the thanks.
Fine. I mean, just Indrajit is the secretary of the. He started the organization Diabetes Awareness and You. He was the past secretary. He will be, we are gearing him up to come to the forefront very soon. We have got a lot of work, a lot of social work which are coming in now, and we had a very good seminar, the annual conference where Dr. Shomik Goswami, they were all there. They were a big part of our team. So I consider him to be as good part of day. As Shomik missed out my name, I was very happy to believe that he's doing his job from day. And lastly, before I hand it over to Indrajit, when Shomik was talking about the ambit, I would just conclude that we are actually very ambitious now with what Professor Ghosh was saying about the possible cure for death. So this is something that DAPA has really opened up. The SGLT2 inhibitors are opening up for all of us, cardiologists, nephrologists, diabetologists, all the cardiometabolic renal, the continuum of life, and we prevent death. So Indrajit, it's over to you.
Thank you. Thank you, Dr. Basu. Hello. Am I audible?
Yes, you are audible.
Thank you, Dr. Basu, and thank you, Dr. Goswami. On behalf of DAY, thanks are on to all our esteemed faculties and panelists for their time and their expert views. And definitely it's a very good session. And in a peak hours, there are 120 participants. And thanks to the ESI authorities for giving us this opportunity. This is the biggest Indian Eastern India ESI update on diabetes treatment and management. And one thing's come out in the session that empowerment, education is the most key point, and empowerment of patient. And we are since our beginning of the organization for the last 14 years, we are doing the empowerment of the patients who are different activities, and this type of sessions are doing under our capacity building. And you definitely will appreciate that under the capacity building arms, we are regularly doing CMEs for the diabetes educators also. As Dr. Basu mentioned that a few days back, we have organized the biggest international conference for the diabetes educators. So again, thanks to all, thanks to, and definitely I would like to extend our thanks to our industry partners, AstraZeneca, USV, Sanofi, and Zydus. And without their help, we cannot do this program. And thanks again, and good night from to everybody, all the participants on behalf of DAY. Thanks a lot.
Good night to you all.
Good night. Thank you. Good night.
Good night.
Deepak, bye.
Good night, sir.